Welcome to our webinar, Ask the MDS Expert. Thank you for joining us. My name is Lee Clark, Director of Patient Services, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of our patients, families, and caregivers for supporting the program today. It is possible you may lose your connection during today's program. If you do, and you're unable to view the webinar online, you can call in to hear the audio portion of the program using your call-in number in your reminder email. Today's program will be archived and available within 2 to 3 business days. You will be notified when it is live and ready for viewing. This is a Q&A session, so please feel free to submit your questions at any time during the presentation. To submit a question or comment, open the Q&A window in the lower part of your screen. Type in your question or comment in the small text box window, and when you have finished typing, just hit enter. We'll do our best to get to everyone's questions today. When asking questions, I do ask that you do 2 things to help me manage the incoming questions. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our speaker cannot answer any specific questions related to your personal health care. Today's specialist is Dr. Jason Mendler, who is an associate professor of oncology. He received his bachelor's degree from Washington University in St. Louis, Missouri. He then went on to earn his PhD in genetics and his medical degree at the University of Rochester School of Medicine and Dentistry in Rochester, New York. Dr. Mendler completed his residency and served as a chief resident of the University of Rochester Medical Center Department of Medicine. He completed a clinical fellowship in oncology at Ohio State University Medical Center in Columbus, Ohio, and he served 1 year on the faculty as a clinical instructor. Dr. Mendler is certified by the American Board of Internal Medicine, and his clinical interests include acute leukemia, CML, MDS, bone marrow transplant, and myeloproliferative diseases. Welcome, Dr. Mendler. Thank you for joining us today.
Thanks for having me.
When we get started, let's start off with, what is MDS?
So MDS is I consider it a cancer of the blood and the bone marrow that basically results in an inability of a person to make enough of the blood cells that they need. There are 3 main types of blood cells that are affected in MDS, or can be affected in MDS: the white blood cells, the red blood cells, and the platelets. And so patients with MDS have too few of at least one of those types of cells. So when you ask me what MDS is, it's a cancer of the blood that results in ineffective production of at least one of those 3 types of blood cells. The other thing I would say about MDS that distinguishes it from some of the other blood problems that can cause low blood counts is that the cells look very abnormal when you look at them under a microscope. And that we call dysplasia. So that's where the dysplasia comes from in myelodysplastic syndrome.
Thank you. And how is MDS treated?
So the MDS is treated not in one standard way, and that's because the way it presents is different in every patient. So the treatment has to be very tailored to a specific patient. One important thing to think about in MDS treatment is what the risk status is of somebody. So patients with MDS, when they're diagnosed, are stratified anywhere from very low risk to very high risk. And treatment depends on what risk category someone is. So for higher, intermediate, high or very high risk patients, we usually treat with a drug called azacitidine, which is a type of drug that's in a class called hypomethylating agents. There's another drug called decitabine that we use. So either of those drugs is used in higher risk myelodysplastic syndrome. And if a patient is eligible for a bone marrow transplant, we think about a bone marrow transplant for patients with intermediate and higher risk MDS. For patients with lower risk disease, we are usually focused on trying to improve the blood counts. The most common low blood count in lower risk MDS is the red blood cells, otherwise known as anemia. Anemia in MDS is often treated with growth factors. An example of that is Procrit or Aranesp. And those drugs are used to kind of boost the red blood cell production in MDS. So in terms that there are newer treatments that are available in lower risk MDS for patients with lower risk MDS and anemia. One of those is called luspatercept. But to put it simply, the treatment of MDS depends a lot on the specifics of what risk status somebody is, and also what the genetic information tell us about the disease.
Thank you. Are hypomethylating agents considered chemotherapy?
Yes, they are. They are considered chemotherapy. Yes, I guess that I don't have, I probably don't need to expand on that now unless people have other questions.
Thank you. And for patients who are considering treatments such as using one of the hypomethylating agents, Vidaza or Dacogen, what's the difference between the two treatments?
So one of the differences is that the Vidaza can be given subcutaneously, so it can be given as a shot under the skin, whereas Dacogen or decitabine does not generally come in subcutaneous form. It's given as an IV. So for patients who get these treatments in an infusion center, the Vidaza is usually can be given more expeditiously or more quickly because you don't have to, the nurses don't have to place a peripheral IV before they give the medicine. Another difference is that Vidaza is usually given 7 days out of each month, whereas Dacogen or decitabine is usually given 5 days out of each month. There's a newer form actually of decitabine or Dacogen called Incovi, and that's a pill form of Dacogen. So that's just been around for the last year. So that's been a nice addition in the sense that now patients can get a hypomethylating agent for their MDS and take it at home in pill form. And that seems to be as good as the other forms.
Thank you. And this question will actually go into what you were saying. Is this question says, is there anything on the horizon for treating MDS 5Q after Revlimid or Incovi? All I've read seems to indicate that possible treatment for MDS does not include deletion 5Q.
So I think the question is asking, so for 5Q minus MDS patients, and normally those are lower risk patients who have anemia, and the frontline treatment for those patients is Revlimid. So I think that this question is asking what happens in patients who either don't respond to Revlimid or, relapse after they initially respond to Revlimid. If that is the case, that's how I'm going to answer the question. So I think that once a patient with 5Q minus MDS fails Revlimid and Incovi or any other hypomethylating agent, really at that point in time, the options become are a growth factor like Procrit or Aranesp. So that's an option if patients haven't already been treated with one of those agents in order to try to improve anemia. There's a newer agent that I mentioned before called luspatercept. And there's really no data for that I know of, or very limited data in patients with 5Q minus MDS. Luspatercept is approved for patients with a different type of MDS at this point, but luspatercept would be a reasonable option for 5Q minus patients who fail those other treatments. And then the other, probably the best scenario for a patient like that is a clinical trial. So there are, several clinical trials in MDS where if, so I think that would be the first option, would be to find a clinical trial in that setting.
Thank you. This question comes from a patient who is 78. They were on lithium for 32 years, and it caused damage to the kidneys and the thyroid. They were finally diagnosed with MDS in May of 21. Diagnosis was MDS SLD. Doctor is talking about using Procrit. This patient is concerned about the use of Procrit as they already have damage to their kidneys. What are the factors of using Procrit and the risk to a patient that already has some kidney damage?
So Procrit is very safe, actually, and I wouldn't worry at all about Procrit hurting the kidneys. In fact, Procrit and medications like Procrit are used in patients, routinely in patients with kidney failure. So the kidneys normally produce a hormone called erythropoietin that tells the bone marrow to make more red blood cells. And when the kidneys, aren't working as well, part of what happens is that they make less erythropoietin, and that can contribute to anemia. So, forgetting about MDS for a minute, it's pretty common that we see that patients with chronic kidney problems have anemia just because their kidneys aren't making enough erythropoietin. And in those patients, we routinely use Procrit and medications like it without worsening their kidney function. So I think that this person who asked the question shouldn't worry at all about the risk of Procrit or a medication like it worsening their kidney problem.
Thank you. Part two of this question is that both of the patient's parents died from heart attacks and having strokes. Is that a concern with using Procrit?
So there is some concern around that. So there is an increased risk with Procrit of high blood pressure, of blood clots, including strokes. I think there are a couple of things that can be done to manage that risk. So for patients on Procrit, it's really important to monitor the blood pressure carefully and make sure that it's well controlled. And the other thing that's important is that when we use these medications, it's important not to try to push the hemoglobin too high. So, the studies, so really, to my knowledge, people really haven't shown much, if any, of an increased risk of stroke and high blood pressure in MDS patients treated with Procrit. But those risks have been seen more in other settings where Procrit's been used. But in MDS, what we do is in patients on these agents, we try to control the blood pressure. And we, sorry, I lost my train of thought here for a minute. We try to control the blood pressure now I remember. And we try to not push the hemoglobin so high. So while we want to improve anemia with Procrit, we don't want to if someone is responding, we don't want to push their hemoglobin too high. Usually I shoot for a hemoglobin between 11 and 12. And so those are a couple of strategies to decrease the risk of stroke or high blood pressure in patients with MDS treated with Procrit.
Thank you. This question is, the information that I have read says low risk subtype for MDS rarely progresses to AML. Is that true?
So it depends on how you define rarely. There is something called an IPSSR score, the International Prognostic Scoring System -R, which is revised. And so that so every patient with MDS gets a certain risk score at the time of diagnosis. At least that's how I practice, and we use that tool to stratify patients based on risk. And in using that scoring system, you can actually get an estimate of how likely the disease is to progress to AML. In general, patients with very low and low risk MDS have a lower risk on a yearly basis of their disease becoming AML than someone with high or very high risk disease. So, from that perspective, I would say that's true, but the devil is also in the details. There's a lot of genetic information that can help help understand that risk. So both cytogenetic information, where we look at the chromosomes, as well as we do a lot of mutational profiling now in MDS that can help assess the risk of transformation to AML in patients with lower risk MDS. But yes, in general, lower risk patients have a lower risk of their disease becoming AML than higher risk patients.
You had mentioned the hemoglobin and the goal of where that should be. So this question goes in line with that. The question is, my hemoglobin has 9.4. Both of my doctors, which would be a hematologist and a nephrologist, consider my overall CBCs to be stable for the past 14 years. When should I consider treatment, specifically Procrit, if at all?
Yeah, so that's a good question. So I think a lot of it really depends on your symptoms. So, symptoms of anemia can include shortness of breath with exertion, chest pain, fatigue. So I think in this case, if I felt like, there were symptoms, this patient were having symptoms due to their hemoglobin of 9.4, then I think it would be reasonable to treat with Procrit. On the other hand, if this patient is basically living, a pretty normal life and doing everything that they want to do and not feeling physically or functionally limited in any way, and I would probably continue to monitor. So I would be monitoring this patient, for those symptoms that I talked about before, and sort of looking to see that there are some adverse symptoms related to the anemia before starting treatment.
Thank you. Our next question says, I think that typically Vidasa quits working after 2 years. Do you know how long they expect Inqovi to control the disease as well?
Yeah, so, the data with Inqovi is not as mature yet, but it's probably going to be very similar to what we've seen with Vidasa. The studies that led to Inqovi's approval basically show that the levels of drug that you get in the blood are the same as with the IV form of Dacogen or decitabine, and most studies have shown that this Dacogen or decitabine is relatively similar to Vidasa. So I think, you know, I don't think that INCOVI is, I think INCOVI is going to be very similar in terms of expected response rates and duration of response. I think really the advantage of INCOVI is the fact that it's in pill form.
Thank you. When should a patient consider a transplant?
So a patient should consider a transplant if they have intermediate or higher risk disease. You know, and I use the IPSSR score to determine that. And if they're, you know, at our center, we transplant patients up to the age of 75. So I would say if they're, you know, below the age of 75 with intermediate or higher risk disease, and, you know, if they're fit, you know, very fit, you know, and sort of, you know, pretty just generally well with respect to or relative to others their age, and then they should, you know, consider transplant. For sure, you know, younger patients with MDS, so primarily MDS is a disease of you know, relatively older people. I don't want to offend anyone on this webinar, but you know, patients over the age of 70, but sometimes we see patients who are in their 40s or 50s or even younger. You know, for sure in those patients, you know, we're thinking transplant right out of the gate. But the bottom line is anyone who has, you know, relatively higher risk disease and is pretty fit from a physical and functional standpoint should at least be evaluated by a transplant physician.
Thank you. Our next question is from a patient who was officially diagnosed in 2018 with low risk MDS and PNH. They have SETBP1 trisomy 8 mutations. They've started Impavli for PNH, which they are tolerating well, and their lab numbers are very good. With the overlap of PNH and MDS, how is a person to know if MDS is advancing? Is a bone marrow biopsy recommended every few years or only when something arises that is suspicious?
Yeah, that's a very good question. And I think that this can pertain, this is you know, a complicated patient with both PNH and MDS, but this kind of can pertain to anyone with MDS in terms of sort of monitoring it for, you know, when things are getting worse. And I think, you know, you do that by both, you know, by looking at the CBC, so the blood counts. So, you know, if blood counts get worse, that's a sign that perhaps the MDS is getting worse. If someone's physical and functional status gets worse, that's a sign that maybe the MDS is getting worse. So in those situations, I think, you know, a repeat bone marrow biopsy makes sense. And we routinely do, you know, routinely MDS patients have bone marrow biopsies at various intervals of time to assess the disease status. So, you know, in a patient like this who has PNH and MDS, so every time so what you're looking for, I think it sounds like right now the patient is doing well on treatment for PNH. So I think as long as their physical and functional status is stable and their blood counts are stable, really they don't have to do anything else. But if the blood counts get worse or their physical and functional status gets worse, then they need both a bone marrow biopsy and a reevaluation of their PNH with testing for the, you know, to see what the size of their PNH clone is and that sort of thing to, you know, to figure out sort of which component is playing more of a role.
Thank you. You may have already answered this. I don't know if you want to add, but this is the info I've read about the side effects of transplant terrifies me. How do people decide on the length of life versus quality of life?
So I didn't answer that. And it's a really good question. And I think it's a very individual decision that a patient has to make. There are a lot of factors that go into that decision. I think, you know, depending on the age of the patient, depending on their values, depending on how important length of life is versus quality of life, that varies a lot from patient to patient. So all of those factors go in. I think that it's easier for patients who are relatively younger and are otherwise relatively healthy, who have very high risk disease. So in those patients, in some ways, they really don't, if they don't do a transplant, then they're like, the likelihood is they're going to live for a very short period of time because they have very high risk disease that's likely to transform to leukemia and be difficult to treat. So I think when you have the younger patient who has very high risk disease and is otherwise pretty well, they're much more willing to take a risk because the risk of not doing transplant is so high. So, it's a great question. And it involves a lot of extensive discussions with the patient. So I myself don't do the transplant piece, but for patients of mine who are considering transplant, I speak to them quite extensively about transplant. I have one colleague in particular who does most of the transplants for, my patients who have MDS, and so he will talk to the patients for a long time and about the risks and benefits. So from our end, we just want to make sure that the patients have all the information that we can give them to help make that decision. But it's a very individualized decision that varies a lot from patient to patient.
Thank you. This question comes from an MDS patient who has deletion 5q, was diagnosed 4 years ago at the age of 53. They've been watch and wait and have never required a transfusion. Labs are generally within normal range or just below. The local doctor wants to start Revlimid. They did receive a second opinion from an MDS expert who would like them to remain watch and wait unless they become symptomatic. What is symptomatic? The person does experience being very tired, lots of joint and bone pain, and they even find it difficult for working in the yard and taking a shower. So they'd like to know what is symptomatic. How do you know when to start treatment?
Yeah. So another really good question. So starting treatment in 5q minus MDS for a patient with a pretty preserved, pretty good hemoglobin, it sounds like, but some symptoms that are bothersome. I think that, so the obvious symptoms that are related to anemia in MDS are fatigue, shortness of breath and shortness of breath with exertion. Okay. The problem with fatigue in particular is that a lot of things can cause fatigue. Anything can cause fatigue. So in patients with MDS, it's often difficult to know how much of their fatigue is due to their MDS versus maybe something else that they have going on, some other medical problem, or the possibility that they're not sleeping well at night. My feeling is if someone has a hemoglobin that's almost normal and is feeling fatigued, it makes me think it's less likely related to their MDS and more likely related to maybe some other medical issue that might be going on. Now, to complicate matters more, sometimes patients with MDS develop what's called a paraneoplastic syndrome. So they can develop basically other symptoms that are not necessarily usual in MDS. So for example, joint pains, I hear this patient has joint pains and maybe muscle aches, and basically symptoms that aren't usually associated with MDS sometimes can be associated with MDS, even if the blood counts are relatively normal. So, and in that case, a lot of times what I'll do is I'll have them see a specialist. Like in this case, if fatigue and joint pains are prominent and the blood counts are pretty normal, and I don't know if they're related to the MDS or not, I will often have them see like a rheumatologist to rule out some other type of problem that may be there before attributing it to the MDS. So, getting back to this patient, whether or not they should be treated, I think some of that depends on if the symptoms that they are having, if there's no other good explanation for the symptoms other than the MDS after they've seen other doctors to evaluate for other diagnoses, then I think it would be reasonable to treat with Revlimid. The other thing I was going to say is that there's actually newer data that it used to be that we waited with Revlimid to treat patients who were with 5q minus MDS that were very symptomatic or quite anemic and requiring transfusions. There's newer data that shows that treating those patients actually with treating 5q minus patients before their anemia gets really bad, so when their hemoglobin is in the 10 to 12 range, if you treat those patients with half of the usual dose of Revlimid that we normally use in 5q minus MDS, then that can delay the progression of their anemia and delay the time to when they would need to receive their first transfusion. That was data that was presented at ASH this past year, actually. I can't remember the name of the study off the top of my head. It was a European study. So I think, again, I don't want to give any specifics to this patient in terms of recommendations, but hopefully that answers the question or at least gives them more information.
Thank you. What is the benefit of combination therapies for treating MDS, such as Vidasa and venetoclax?
Yeah. So, that's right now, being tested in clinical trials. So I think the answer is we don't know for sure yet. The specific example of Vidasa plus venetoclax is an interesting one. So it's being tested primarily in higher risk patients with MDS who are often, very similar to certain patients with AML where that combination is approved. I think what's clear about that combination is that it's pretty effective in clearing out the blasts, which are kind of the leukemia type cells that are present in higher risk MDS patients. But that combination can also really suppress the normal blood counts. So I think people are still wondering how effective that's going to be in treating higher risk MDS. So really there's still no combination therapies in MDS that are approved or that we know of work better than the hypomethylating agents as single agents. There are several drugs in the pipeline that look very promising that hopefully will be coming soon.
Is MDS only diagnosed through a bone marrow biopsy, or can you also receive the diagnosis from a blood test?
So you can diagnose, I would argue you can diagnose MDS from a blood smear, as well as what we call, as well as certain genetic and molecular tests that are run from the blood. So in order to diagnose MDS without doing a bone marrow biopsy, a hematologist or a hematopathologist would need to look at the patient's blood smear and look for signs of dysplasia, which are abnormal appearing cells. And then that patient would also need to have some testing of their chromosomes, as well as mutation profiling. And I think if all of that lined up and was consistent with MDS, you could probably make the diagnosis of MDS from the blood. Now, that said, you really shouldn't make that diagnosis only from the blood, except for select cases, because you can't get all the information you need to do an accurate risk stratification without doing the bone marrow biopsy. So in general, 99% of the time I'll do a bone marrow biopsy if I'm, worried about MDS, unless, a patient just is really opposed to doing it. And, so I guess the answer is you can kind of make the diagnosis without a bone marrow, but the bone marrow really is strongly preferred, bone marrow biopsy.
Thank you. This question is, the FDA and drugs.com state in their medication guides, Procrit has not been proven to improve quality of life, fatigue, or well-being. Do you think this is true, and is it worth the risk?
I don't think it's true. I think Procrit does improve quality of life. And I think, again, I think the risks of Procrit are quite small, as long as the person prescribing it is paying attention to make sure that the hemoglobin is not going too high, and that the blood pressure is well controlled. In my experience, Procrit probably helps about 40 to 50% of patients who are treated with it. It often doesn't work all that long. So in the randomized, there are now 2 randomized studies out of Europe that looked at the benefit of Procrit in one study, and darbepoetin or Aranesp in the other study. And in those studies, on average, the benefit was about 200 days, so not even a year. So Procrit is not great, but in certain patients, it really boosts the hemoglobin, and I would say, clearly improves quality of life in my experience. So from a clinical standpoint, I think Procrit is, is a good option. It's just, and I've had some patients who just respond exceptionally well to it for years. So, for those patients, it's great. That's not the norm. So while Procrit is pretty limited, I feel like it does improve quality of life, and it's relatively safe. And so it's worth a try.
Thank you. Our next question is, a patient was treated with Rituxan from 2011 to 2017 for follicular lymphoma. They then had a bone marrow biopsy in 2018, diagnosed with MDS. No treatment other than they've had 24 red cell transfusions. Then in late May 2011, they were diagnosed with ALK. They'd like to know, do you think that both of these blood cancers are due to the initial Rituxan treatment? And what is possible treatment going forward and prognosis?
Yeah.
Which I know is difficult to answer.
Yeah. I mean, the one thing I don't know is I don't know what ALK is. I don't know what that is. I mean, so I can speak to the MDS, but I don't know if they can clarify.
It says ALK, ALCL. Are you
Oh,
familiar with
okay.
those?
ALK positive anaplastic large cell lymphoma. Okay, so this poor patient, first of all, I'm sorry for what you're going through. This is a very difficult situation. So first off, what I would say is that to my knowledge, rituximab does not predispose patients with lymphoma or any patients who are treated with rituximab to MDS. So I think it's unlikely in this case that the rituximab contributed to the development of MDS. It's very hard though to know, it's hard to know for sure. If this patient had gotten, certain other types of chemotherapy, so rituximab is an antibody type therapy, but if this patient had gotten what we call cytotoxic chemotherapy for the follicular lymphoma, then it would be more likely that would have contributed to the MDS, in which case we would call it a therapy-related MDS. But I think in this case, it's probably not a therapy-related MDS. It's probably just bad luck that this patient had follicular lymphoma and then developed, an MDS. Some of that, some of the details of the MDS matter in terms of trying to figure out if it's therapy related versus, not related to treatment. And we don't have that information from this question, but that can be helpful in figuring that out. Although I'm not sure it's clinically that useful to know. In terms of the ALK positive, positive ALCL, so that would be a separate type of T cell lymphoma that is probably unrelated to the follicular lymphoma. I'm not a lymphoma doctor, by the way, so I do know some about lymphoma, but my understanding of that type of lymphoma is that it's relatively treatable. The problem is that, and I think this patient was asking about prognosis, correct, Lee?
Yes.
Yeah. I mean, the problem is once you start getting multiple cancers in a patient, it's often very, very difficult. And, I think that in the prognosis is worse, understandably, I'm sure, than if you were dealing with one of those cancers alone. Because it's common that the treatment for one type of cancer, for example, if you wanted to treat the anaplastic large cell lymphoma with chemotherapy, that often will suppress the blood counts, will kind of injure the bone marrow. And if the patient has MDS, their bone marrow is already injured. So a lot of times you can't give patients with lymphoma the same amount of treatment or the same treatments you would normally give them if they didn't have MDS, if they do have MDS, because their bone marrow won't tolerate it. So again, this sounds like this patient's in a difficult situation. I do think what's important in a case like this is that a patient is treated at an academic medical center where there's a lot of subspecialty expertise in the different cancer types so that the optimal treatment plan can be put forward.
Thank you. Our next question is, can Revlimid be used on patients without 5q deletion?
It can. I mean, there's some data for doing that. It's something that's reasonable to try for patients with lower risk MDS. who do not have a deletion 5q and who have like either not responded to or failed, who have failed Procrit, who are not candidates for luspatercept or who have failed luspatercept. It's not unreasonable to try lenalidomide. The response rates aren't very good. They're on the order of 20 to 30%. So it's unlikely someone's going to get much of a response. And sometimes Revlimid's difficult to tolerate, but it's worth a try.
Thank you. Can NCOVI be used as an only treatment?
Incovi is only used as an only treatment. I think, are they asking, is it only used by can it be
By
used
itself?
by itself?
Yes.
Yeah,
It just says, what is your opinion of NCOVI? Can it be used as an only treatment?
Yes, I mean, that's what the label is. At this point, it's not even approved to use with anything else. It's being tested with other treatments, but the answer is yes, that's the only way it can be used.
What is hypoplastic MDS and how is it treated?
Yeah, so hypoplastic MDS is, I think of it as, almost like what we call aplastic anemia. So it's where normally in MDS, when you look at the bone marrow biopsies of patients with MDS, there are actually more cells than usual. So it's called hypercellular, which is kind of counterintuitive because the problem with MDS is that you have low blood counts. But in MDS, the bone marrow is trying to make more cells. It's just that they're dying off fast and it's ineffective. But the bottom line is normally the bone marrow biopsy shows too many cells in MDS. But occasionally in MDS, you see a situation where you have too few cells. And that's what we call a hypoplastic MDS. Sometimes that can be difficult to distinguish from aplastic anemia, which is a different bone marrow failure disorder. So the difference between aplastic anemia and hypoplastic MDS is that in MDS, the cells, have to show dysplasia or appear very abnormal. Whereas in patients with aplastic anemia, there are too few cells, but they look relatively normal. The genetics and the mutation profiling can sometimes help distinguish between the two. So in hypoplastic MDS, those patients are often treated a lot more like aplastic anemia patients with drugs that suppress the immune system. So for example, we use medications called ATG or anti-thymocyte globulin, often with another medication called cyclosporin and eltrombopag. So that's a standard treatment that we use for aplastic anemia that we would be more likely to use in a hypoplastic MDS. So hopefully that answers the question.
Thank you. This question comes from a patient. I've been trying to get a diagnosis for a little over 2 years. Finally received a diagnosis of MDS unclassified. What does that mean?
So what it means. So what does MDS unclassified mean? So if you look at books that are written by hematopathologists, the most common book used is called the WHO classification of tumors of hematopoietic cells. In there, if you look under the section for MDS, there are lots of different categories of MDS. For example, there's MDS with excess blasts, there's MDS with ring sideroblast, there's MDS with multilineage dysplasia, there's MDS with 5q minus. So there are a lot of different categories of MDS that are based on the morphology, so how the cells look under the microscope, and also based on certain genetic information. So sometimes, despite there being, I think, I mean, I don't remember how many different classifications there are of MDS. There might be 7 or 8 different WHO categories at this point. Sometimes there's a patient that, meets enough of the diagnostic criteria that they're called MDS, but they don't fit neatly into one of those categories. So then they fall into this MDS unclassifiable because they don't fit into any of one of those categories. So from a treatment standpoint, it's not really that important, in terms of the treatment options and in terms of the risk categorization. But it's just sort of the way that we divide up, or that hematopathologists divide up MDS based on how things look.
This is in regards to a switch from Dacogen to Encovi. The patient has been doing very well on Dacogen, but would like to consider switching to Encovi just for the convenience of being able to take treatment at home. Do you know of any risk of switching from Dacogen to Encovi? And if they decide to do that, what is the process?
Yeah. So, I mean, in theory, it should be fine. I mean, it's, it's the same drug, and studies have shown that the blood levels are the same between the IV and the oral forms of decitabine. So I wouldn't have any problem with this patient switching to Encovi. And the process is usually, at least at our institution, is pretty easy. We have a pharmacist who works at our specialty pharmacy who's embedded in our clinics that helps us figure that out. Obviously, insurance needs to approve it, but that hasn't, so it's not that, it hopefully shouldn't be much of an issue. The one problem, in going to Encovi is that you can't change the dose of each. You can't change the dosing. So what I mean by that is some people who are on decitabine or IV decitabine or Encovi, develop really low blood counts when they're on treatment. And sometimes and that's because those drugs, even though they're designed to improve the blood counts in MDS, they can sometimes make things worse before they get better. And sometimes when you give the usual dose of Encovi or decitabine, which is 5 days of treatment at a specific dose, sometimes it's too high of a dose for a patient. With the IV form of decitabine, it's easy to dose reduce. So we usually give 20 milligrams per meter squared per dose. But if someone's having really low blood counts, sometimes we'll drop the dose to 15 or to 10. But with Encovi, you cannot break up the pills, and there are no other dosing formulations yet for Encovi. So one of the downsides is you can't modify the dose. The only way you can modify the dose of Encovi is by giving fewer days. So normally you give 5 days, so you could give 4 or 3. But so far, that's what I've seen as one of the drawbacks of going to Encovi. But I think in this patient, it's very reasonable to try the Encovi, and you can always switch back.
Thank you. And this is another Encovi question. It says, what is your success rate with patients on Encovi with intermediate risk score? The patient just completed 6 dose pack. His body could not handle every 28 days, but seems to be doing well every 6 weeks. Mm-hmm. His white count neutrophils are slow to recover. Just wonder how long this treatment continues. Is it months, years, or ongoing for life?
Yeah. So It's probably, it sounds like this patient's responding reasonably well. Like I just mentioned in the answer to the last question, it's pretty common sometimes for patients' blood counts to not be ready to receive their next cycle exactly on time. So sometimes rather than getting it every 4 weeks, they give it every 5 weeks or 6 weeks. I would say, sometimes people, hopefully this patient had a repeat bone marrow biopsy. And if that shows that things are getting better or in remission and the blood counts are relatively good and the patient's feeling well, they could get a good year or two on treatment like this. If they're very lucky, they could get more than that. There are a very small subset of MDS patients that have extraordinary responses to hypomethylating agents that last 5, 6, 7 years. I have one guy who's just getting ready to get his 100th cycle of Vidasa, which is extremely unusual, but you can rarely get that. So I would say, a reasonable expectation would be, 1 to 2 years, for this patient, maybe longer with intermediate risk disease. It's hard to know. And I don't know all the details. Like I don't know what the blood counts are exactly. And I don't know what the bone marrow biopsy showed after the 6 cycles. For me personally, I don't have, in my experience with the hypomethylating agents, for patients who respond well, they will often get a really good year or two, and then usually things start to progress at that point.
Thank you. And our last question is, this is from a patient who has MDS, MPN, RARST, was diagnosed with a bone marrow biopsy 5 years ago. They'd like to know, what does it mean when your platelets continue to decrease, and what are the usual treatments?
Yeah, so great question. So this is a pretty rare form of an overlap disorder. So what does it mean when the platelets decrease? So, usually patients with this disorder have high platelets. That's where the thrombocytosis comes in. So some of it depends on what kind of decrease we're talking about. Again, it's a little bit hard for me to answer, because if you go from 700, which is high, and now you're at 500, which is still high, that's different than if we're at 700 and now you're down to 30. So the degree of decrease matters. Usually in this disorder, the prognosis is relatively good, and relative to other types of MDS and overlap disorders. And these patients usually are treated with a baby aspirin to decrease the risk of blood clots, which there's usually an increased risk in these patients. Sometimes these patients will get hydroxyurea to manage the platelet count and to keep that in a relatively normal range to decrease the risk of blood clots. And sometimes actually these people, sometimes these people can have pretty significant anemia. So, they could be treated with Procrit or luspatercept. So a lot of it depends on, how the blood counts look and what the symptoms are. The truth is, we still don't really know how to treat MDS, MPN overlap disorders well, and that's an active area of clinical investigation.
Thank you so much, Dr. Mendler, for sharing your time, your expertise, and answering all of these great questions for us today. If you'd like to watch this webinar again at a later time, it will be available on our website within 2 to 3 business days. If you have any additional questions, please send it to us at any time in 3 ways. Send an email to us at help@aamds.org, call our helpline at 800-747-2820, extension 2, or submit your question on our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, I'd like to thank you for joining us and making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are always here to support you and your family, as we've done for the past 38 years. This concludes our program. Thanks again, Dr. Mendler. Have a great day.
You're welcome. Thank you.